our speaker. Dr. Meza is a graduate of Vanderbilt University, where he received his BA in psychology. He received his DMD from the University of Connecticut School of Dental Medicine. And after graduating from dental school, Dr. Meza went on to receive his specialty training from Temple University School of Dentistry, where he obtained his certificate in endodontics. During his residency program, Dr. Meza actually conducted research using the erbium chromium YSGG laser to investigate its effectiveness in disinfecting root canals. The promising results of his research led to a publication in the Journal of the American Dental Association, volume 138, and that was back in 2007. Dr. Meza is originally from El Salvador and fluent in Spanish. So one time you'll have to give this to us in Spanish, please, Dr. Meza, and grew up in Northern Virginia area where he maintains private practice to this day. It's my pleasure now to turn this evening's presentation over to Dr. Fernando Meza. Dr. Meza, take it away.
I'm excited to present to you a webinar here titled The Power of Photoacoustics, Unleash Your True Potential with All Tissue Lasers. Basically, we're looking at the Waterlase iPlus. That's the laser that I have here. That's a photo of the operatory, one of our operatories here in Arlington, Virginia. And what you see next to you right there on the right side is a handpiece with a RFT2 tip. That's a radial firing tip that's 200 microns in diameter. And what you're seeing there is the laser beam. That's an aiming beam. It's a class 1 laser, and it shows basically a radial sort of projection. And that's what's fundamental to a lot of the photoacoustic effects that we can have inside the canal system. So I just wanted to show you that, and it's essentially basically a fiber. It's a little glass fiber that's somewhat flexible. And so just wanted to show you what we're using here. So imagine a mechanism or technique where you can apply minimal or conservative mechanical instrumentation of a root canal system, remove dentin, dentin debris, remove smear layer, and disinfect and disrupt biofilm, bacteria, effectively remove vapor lock, and decrease potential adverse effects of sodium chloride use. We can remove the dentin debris. We can remove smear layer. We can disinfect and disrupt biofilm bacteria. We can effectively remove vapor lock, and we can decrease potential adverse effects of sodium chloride use. So that effect basically is a photoacoustic effect. And with the erbium chromium YSGG Waterlase iPlus laser, you're inducing vapor bubbles that instantly expand and implode, resulting in acoustic streaming and cavitation effects in the intracanal liquid. Pressure waves are created from the expansion and contraction of the vapor bubbles. The jets with imploding bubbles are also created. The resulting pressure waves and jets create a shear stress along the root canal walls. So fluid speeds of up to 20 meters per second, equivalent to about 45 miles an hour, have been recorded. And that's from a Blanken study back in 2009 and 2007. He goes on to say, new bubble formation occurs at apical end due to low pressure created by cavitation effects. Fluid turbulence remains after each laser pulse. Bubbles formed can have a volume of 1,600 times the original volume, and therefore considerable pressure gradient arises in the root canal system. So what you're having there is these bubbles that are just starting to be formed from the activation of the laser, and it's creating these vapor bubbles that get larger and larger. And so in a confined space, they have to move somewhere. And so what ends up happening is you have a fluid pump which is created within the root canal system. And as you're using the fiber tip that I showed on the first slide, you can actually see debris and bubbles arise up through the orifice into the pulp chamber, especially under a microscope as we use in endodontics. So it really creates a fluid pump and quite a bit of shear stresses in the canal system. So those shear stresses are sufficient to remove smear layer, dentin debris, disrupt biofilm bacteria, and also remove vapor lock. Those bubbles, as I mentioned, are in the dentin debris, and even in retreatments, you can see small bits of gutta-percha after the bulk of the gutta-percha is removed are noted at the orifice level, and that's using that RFT2. That's a radial firing tip 2, available at 17 millimeters and 21 millimeters. And you can see these when you apply this tip when it's at the mid-root or 5 millimeters from the apex. Here's a video I hope to be able to to play for you here. I created this video actually myself. It's an acrylic block. It's about 30 millimeters long. And what you see on the left end of it is basically a radial firing tip 2. And the setting here is actually the clean and shape setting on the machine. And it's at 1.25 watts, 50 hertz on H mode. And it's equivalent to 25 millijoules. All these settings are very simple to move up and down. As you start to get more, experience with the laser, you can kind of play around with those settings, but they're really pretty good as they are. So this is hopefully a video you can see here of the photoacoustic effect. You can see the bubbling action way down all the way to the tip there, almost 30, millimeters away or so, 27 millimeters away. And so that's what's so powerful about this, is that you get this bubbling cavitation, we call it. We'll go into those. I'll just play that one more time for you. But as you can see, this bubbling action is what we're talking about, can disrupt biofilm, bacteria, remove dentin debris, and also remove smear layer at a distance. We'll go on to the next slide here. Have a couple more videos for you. And that is, again, photoacoustic effect here. Clean and shape, 1.25, 25 millijoules. Okay. I'll play that for you one more time. That is a clean and shape mode. And what I'm trying to show here is on the right side, which I'll play next, is a disinfection mode. And what you're seeing there is you're seeing an increase in the millijoules, the energy that is used, that can be applied with this laser tip. And so on the right side is 0.75 watts at 20 hertz at H mode. So what you'll notice there is the hertz went down. As the hertz go down and the wattage goes up, ultimately you are increasing in the energy potential that's released through the fiber. And so the left-hand side is going to be smaller bubbles at 25 millijoules, and the right-hand side on disinfection mode is going to be higher millijoules, more energy, with a bit larger bubble, so more power. And so I'll play the left here again on the clean and shape. Here we go. So again, you can see at a distance these little bubbles there that you can see that going back can expand up to 1,600 times. And you get this sort of fluid pump happening. What this is a video that I created. I took a monojet syringe and I just cut the tip off of it. And I put some wax at the end of it. And this just has, I believe, just water in it. But water can work, and so can hypochlorite and EDTA and all kinds of irrigant solutions. So let's go to the right side now. This is higher power now, or higher energy. You can almost, I'll play that again. You can almost hear it. It's, bubbles are larger. The energy is more powerful. Let's play it again. What you'll also notice here, right here, I don't know if you can see my little mouse here pointer, but you can see actually some of the water came out of there. And so you're right away going to say, well, this might lead to extrusion of irrigants out the apex. This is perhaps, maybe there may be some, but clinically there is no hypochlorite type accidents or situations that I've come about, or any of my colleagues that have been using lasers now for 2 or 3 years at least, that we've known about that would cause an accident like this. So this level of slight extrusion of the liquid is clinically is negligible, I would say, because there is PDL, there's bone. But let's just play that again so you can see that. There's a little bit of water there that comes out of there. Okay. And I have a study to show you as well here later on about how you can even get those kinds of extrusions even from syringe irrigation, or not just laser. All right, let's just move along here. Okay, so All right, next one. Okay, so now comes the laser advantage. So basically, it's this powerful photoacoustic effect of water and irrigating solutions within the root canal system. As just as a summary slide, really, that what we're talking about here, it can dentin debris removal, smear layer removal, biofilm disruption, disinfection, and also greater dentin disinfection and penetration. And what we're aiming to sort of show you here is that perhaps less mechanical instrumentation and apical canal enlargement is needed here, and you have increased wall stresses with lower apical pressure. Some definitions here. So there's acoustic streaming and there's cavitation. So acoustic streaming occurs also with ultrasonic irrigation. It's basically a wave that's propagated in a viscous fluid, produces a directional flow velocity and oscillatory motion known as streaming. And so we do see this with our ultrasonic units, but as I'll mention with the ultrasonic units, one of the problems is that as the tip is oscillating, it can contact the canal walls. And this is something that is just not seen with the laser tip. You can touch the canal wall temporarily and you will not get a dissipation of this or a dampening effect of the photoacoustics or the cavitation or the streaming. But it is apparent in the ultrasonic units. So cavitation is actually where you have the vapor bubbles actually, grow and they oscillate, resulting in expansion and implosion, the collapse of the bubbles resulting in jets. So when you have a vapor bubble created, it starts to grow, and then subsequent more vapor bubbles are also generated from the continuing action of the laser. But as the pressures change, then and you basically have an implosion of the bubble, and as the bubble implodes or collapses, you actually release creates a jet through the bubble that causes strong shear forces. This is basic cavitation in liquids, and this happens again in the hypochlorite or in the water as well. And this happens within the canal. And this is kind of the hallmark of why the laser is so useful in endodontics, as you'll see. So passive ultrasonic irrigation, just going over some of that. Yes, you basically have oscillations of a set amplitude that generates acoustic streaming and cavitations, just like like you would in the canal with liquids. And it's usually a non-cutting protocol. You don't want to be touching the canal walls because it's just not a very effective method to instrument a canal wall with the ultrasonic units. It's important to make the distinction between continuous ultrasonic activated irrigation and also intermittent ultrasonic activated irrigation. So the continuous could be, even from the orifice level, or it could be also what was a piezo flow unit that allowed a continuous fluid to flow through while you're activating the ultrasonics tips. Intermittent would be that you're placing a fluid or liquid into the canal or chamber and stopping at that point, and then just going back to the ultrasonic unit and activating it. And some of the fluid may dissipate out, and then you may want to syringe irrigate again and repeat the process. Both of these techniques actually can be used with the laser as well. You can have your assistant continuously irrigate the chamber for you as you activate the laser tip in a withdrawal stroke, or if you keep the laser tip as well in the pulp chamber, you can achieve a continuous type of solution. You can also do it intermittently by, and this is kind of a lot of the ways that I work with it, is I fill the chamber with irrigating solution or sodium hypochlorite, and then I'll activate the laser on a withdrawal stroke or leave it in the pulp chamber as well. And then I'll just rechange out my solution after, by syringe irrigation. So onto a vapor locked effect. This is an effect that happens where you have gas bubbles that are entrapped in the apical third or also middle third of the canal system. And the reason this happens is you've got additional irrigating solution coronal to the bubble. You've got periodontium apically to it, and you've got your canal walls laterally to it. So it entraps basically a gas bubble that may form. The reason this is important is that it prevents your irrigating solution from reaching the apical end to properly disinfect that region of the root. Now that I've given some of those definitions, I'd like to go into some of the limitations of what we might call conventional endodontics, or I'm basically saying endodontics prior to laser use. So I'm kind of lumping it into that form. So two limitations are, of course, our syringe irrigation may potentially be inadequate because of the vapor lock effect specifically, and also because it's difficult to get to the apical end and properly irrigate to clean and disinfect just using a syringe. Also, mechanical instrumentation, there's limitations to that too. I mean, we don't want to, instrument too large, and you'll see that these are kind of interrelated. You almost have to instrument to 30 or 35 or even a 40 perhaps to properly get proper use of syringe irrigation. And these are some of the things that I highlight that are some of the problems or limitations currently, and that hopefully with laser and the photoacoustic effect, you can have a solution to this. So here is the syringe irrigation conundrum again: needle size, canal preparation size, vapor lock, also the possibility of apical extrusion. That's always a fear for endodontists. You don't want to be, potentially having a hypochlorite accident. You decide maybe you don't want to put the syringe tip down too far down the apex. In some cases, you just can't because the canal is just too small to begin with. And so you wonder if you're actually properly disinfecting and debriding your system there. So these are kind of interrelated, but so apical contact of irrigating solution is important. Fluid dynamics, how turbulent is that velocity of the fluid that is emitted through a syringe. You're not going to have cavitation with syringe irrigation. You will have it with ultrasonics, but you just won't have it with syringe. And so these are just some of those limitations. Again, what you do want is you want coronal outflow of the irrigating solution as opposed to apical outflow. We never want that. And in the outflow, you also are wanting to see the dentin debris and bacteria and bacterial products and biofilm to be, kind of flushed out of the system. That's just one of the how we try to clean and disinfect the root canal that we're treating. Of course, the last one's prevention of apical outflow of irrigating solution. That's important as well. Again, some of the limitations, and this is just a lot of busy slide here. Sorry about that, but it just kind of highlights that that you pretty much are needing to open it to a 3006 perhaps in order to reach working length with a 30 gauge needle. In this study, basically, working length, the solution could not penetrate to working lengths and root canals of a 2006 or a 2506. So you're having to kind of spend more time with mechanical instrumentation into a tooth that perhaps maybe the anatomy may be violated, and that's just not, and so this is where the laser comes in, is you're able to more properly disinfect and debride a system with a smaller apical size. All right, so let's see. In that, here's a study here about apical extrusion. It kind of showed basically that they tested it with lasers. They also tested, again, this is a conventional 25 gauge non-bevel needle. They found, I believe, the Maxi probe to be the best. However, it was, I believe, at 10 millimeters away from the apex, where you'd have almost no problems whatsoever. Again, you have to question yourself as to how good are you instrumenting, how good are you disinfecting with a syringe if you have to be pretty far away in order to prevent any kind of extrusion. I mean, this is an in vitro dye study. So again, even with a syringe clinically, this is just not seen. Let's see here. So yeah, the 10 millimeters from the apex in both showed almost no extrusion of dye. Again, why would you, it's going to be hard to disinfect at that many millimeters away from the apex. So, all right. Yeah, that's why I said here, we must question the effectiveness of syringe irrigation and smaller canal preparations and placements of needles at 5 millimeters and 10 millimeters coronal to the apex. Then, and of course, now in terms of limitations of mechanical instruments, we have the Peters study, of course, that you know, all instrumentation techniques, and of all these 4 that were tested, you have NiTi, K-files, Lightspeed, Profiles, 04. All of them essentially were just left 35% or more of the canal surface unchanged. So we truly do need to have you know, a type of you know, laser, for example, to be able to add to our mechanical instrumentation as well as our syringe irrigation protocols. And here's just a study basically just talking about you know, the vapor lock effect and how you can get rid of it. You know, there is a way to use a well-fitting cone as well as some patency files that might be able to get rid of the vapor lock. But as you'll see in a subsequent study here, you are able to have the laser remove the vapor lock. And again, part of the problem with this vapor lock effect is you're just compromising your action of hypochlorite because you just can't reach the areas that you intend to clean and debride. This is a study where it showed 4 different groups where you had PIPS, which is photon-induced photoacoustic streaming. It's basically an erbium YAG laser, but it's the same concept, and it's the same photoacoustic effect occurs. You have comparison of ultrasonic irrigation, sonic irrigation, and Gutta-percha technique. And what they showed here was that the PIPS laser activated irrigation was the length of the residual vapor lock was shown to be 0 millimeters. Gutta-percha had close to 0, you know, as you're using the Gutta-percha to remove the vapor lock. Ultrasonics, unfortunately, did not seem to dissipate it as well as sonic irrigation. And so the PIPS laser activated irrigation and Gutta-percha technique was able to remove the vapor lock at the apical region of a curved canal. And so it's just a study showing you here that that lasers are able to remove that vapor lock effect more effectively than an ultrasonic irrigation. Just an idea of different techniques here of what's used. GentleWave, for example, I'll talk a little bit more about this. I don't own a GentleWave, but it is available out there. I just wanted to point out that in terms of quantity of irrigating solutions, just to point out to you, GentleWave is probably using about 400 mLs, continuous passive ultrasonic irrigation between 6 and 36, endovac unit, again, between 6 and 36 or so, and then syringe irrigation about 6 to 12, depending on how much you use that. Flow rates, you know, these are, you know, GentleWave is about an 8-minute procedure, I'm told, 45 mLs per minute. And syringe irrigation is typically done about 3 to 4 mLs per minute, mid-root to apex. The others may be a little bit faster. And the reason they are is because they're held a bit in the continuous fashion. You're basically placing this more in the pulp chamber or orifice level. Endovac is more controlled. It can go to the apex, but these are just some of the flow rates that I was able to find just as a comparison between all the different ones here. Limitations here, again, it's this is kind of the hallmark of what's going on with the problems of the passive ultrasonic irrigation, is that we just need a wide apical preparation is necessary. The streaming and cavitational effect may only be about 1 to 3 millimeters from the working length. And then you've got to prepare pretty largely, either to a 3006 or larger perhaps. And of course you have the dampening effect caused, you know, when the ultrasonic tip touches the wall. All right. Here's an interesting study, and then we're going to get into cases because I know everybody wants to see some cases here. Just wanted to show you a few studies. Here's a Demore study, 2010. 4 groups were basically tested, and that was basically passive ultrasonic irrigation, and that was done for 20 seconds in one group. And then you have the same thing, but it was done for a minute. This was using a size 20 air-safe tip. Then you have 2 other groups. One was the erbium chromium YSGG laser, which is the Waterlase iPlus, and that was done for 20 seconds because it was done 4 times it was done 5 seconds 4 times, so that was about 20 seconds. And then you have the fourth group as well, a different type of laser, erbium family as well, and that was also done for 20 seconds. And so the roots were prepared to size 40, okay, using 06 files. So they were kind of largely prepared for all the different modes tested. In the study, they did find that laser activated irrigation, that's what LAI is significantly more effective in removing dentin debris from the apical part of the root canal than passive ultrasonic irrigation or hand irrigation when the irrigant was activated for 20 seconds. That's true. Let's see. Generation of shock waves by dental lasers inside the root canals can play an important role in the dentin debris and smear layer removal. We've been mentioning that. And then there was a conclusion at the end, and this is where I have my own little thoughts about it, but it said that the use of an expensive laser device to obtain comparable results is not necessary. Well, then I said not so fast, because in the study we were enlarging to 4006. That was the final instrumentation size in the study. Also, 1 millimeter from the apex for 60 seconds, which was claimed to be why it was why the results were the same, is not the same as 5 millimeters from the apex for 20 seconds. Let me repeat that. So with the ultrasonic units, you could achieve a similar removal of dentin debris if you held it for 60 seconds, but it was 1 millimeter from the apex. And again, because you have to go to you have to instrument to 4006, I would think that's possible with an ultrasonic unit, because you have to have that tip has to oscillate, and it can't really touch the walls. It has to be sort of free flowing there. That was equivalent to then 5 millimeters from the apex for 20 seconds with the laser. So if you can manage to open it to a 4006 and use the ultrasonic tip 1 millimeter from the apex for a whole minute, then I suppose you would be equivalent to using a laser 5 millimeters from the apex for 20 seconds. And this is where you get into problems when you can't open to 4006 on particularly canals where you have mesial canals of MB, MLs of mandibular molars, or you have mesiobuccals, distobuccals of maxillary molars, for example, or you may have also mandibular incisors. This is where I think the laser really shines, and it's kind of the whole basis of why photoacoustics is so powerful. And so I mentioned that. One last thing here with GentleWave, and then I'll move into the cases. But what is GentleWave? It's a multisonic cleaning technology. It's broad spectrum of sound waves, acoustic energy. It's generated with degas fluids to produce strong hydrodynamic streaming cavitation. Again, I just kind of mentioned here some of the hallmarks of it and comparisons, but 400 mLs of total liquid versus 3 or 4 syringe versus maybe close to 15 maybe or 12 or so of endovac, and then comparing also the flow rate. So it works really well. However, you're using quite a bit of liquid to clean a tooth. And why does it work so well? It's because, again, mainly because of the amount of hypochlorite and the strength of hypochlorite that you're using. In the Hapasallo study, they did show that comparison of bovine piece of meat, 4 by 2 millimeters, at 6%, you had a 2.9 dissolution rate. At 3% sodium hypochlorite, it went down to 2.3. At 0.5, you had it go down to 1. And at sterile water, you almost had no dissolution of it. Sorry, I missed the R right there. The dissolution rate went down precipitously. And so it's not just the action of the acoustics that's generated with the GentleWave. It's not that. It's mainly the amount of time and hypochlorite used in that device that was really the power behind that system. Just before I go to the studies, just a little bit of future potential in photoacoustics. Another study here about vapor nanobubbles. These have been used to disrupt Pseudomonas aeruginosa and Staphylococcus aureus biofilms found in infected wounds. Afterwards, various antimicrobial agents were tested, including chlorhexidine, cetrimonium bromide, mupirocin, and povidone iodine. If the effect is very localized without causing bacteria to be released in the surroundings, this was in infected wounds, and they showed a very efficient way to enhance drug penetration deep into biofilm. So the idea here is that you're disrupting the biofilm first, and then you're adding the antimicrobial, the antibiotic to it. And so this, I throw this out there because perhaps maybe, again, the power of photoacoustics is that you're disrupting these biofilms down deeply into the apical end of the root, and then you're kind of shaking up the bacteria and biofilm, and then you're applying basically antimicrobial liquids, whether it's chlorhexidine or whether it's hypochlorite, and you're just much more effectively disinfecting the system. Okay, I'm going to go ahead with some cases here just to show you. Some of these are kind of recent as well. Had the laser for almost 1.5 years now, and so these are just some cases that I'm going to just share with you. I'm hopefully employing most of what I've said about conservative endodontics, perhaps maybe minimal or conservative mechanical instrumentation techniques, some 3D filling of anatomy that you can see, and also and some faster healing potentially here. So here's a resorptive defect. It was actually a internal resorption, just to show you. The access was, I guess you could go even more minimal than that. It is possible. A laser can do this. But what I want to point out to you here is that on a mandibular incisor, the laser tip is able to give you what I call a crackless access. Oftentimes with a burr, you may, as you go into one of these small teeth, the crown, you may see a little enamel crack, which perhaps maybe is insignificant, but perhaps maybe in 10, 15, 20 years, it grows a little bit bigger. The point is that with the laser, you just don't see that. So you're able to start the access process and continue on. And then reach into your pulp chamber, and then I can then go ahead and use the tip as well that I use for access. It's the MZ6 tip or MZ5 tip, and I can start to remove a lot of that resorptive tissue that occurs there. And I'm able to, also continue on to help me, aid me in finding the canal system there, and then use the photoacoustic effect to also properly debride the rest of the canal system in a fashion where you're not, enlarging the canal unnecessarily. So conservation of tooth structure and complete ability to clean the system. All right. Here's another case. This is actually from Dr. Lee, my business partner. Just wanted to show you how amazing endodontics is, because you never know when you're going to lead to any kind of anatomy that you're just not aware of, unless you take cone beam CT before every patient. Perhaps maybe that's something that's done, or sometimes it's just not done. In certain cases you're running behind, or you just don't think it's necessary, but you're every endodontist will say, that you just never know what you're gonna get with endo here, even after 15, 20 years of experience. And so just looking at that number, 20 here, it looks almost the same as 21. This looks like one canal, but when after using the laser, you can see that they're very different fills here, and you can see the anatomy that's just been filled here on that number 20. So pretty neat. Here's a case of mine here, just showing you again sort of what you don't expect, but kind of going on the idea of 3D filling of anatomy, or what we can call also maybe radial endodontics, thinking more 3D in your fills and how you approach root canal systems. And just showing you here how some of that anatomy can be filled. Laser advantage as well, predictable healing. Here's a case that's a 6-month follow-up, a retreatment case. You can see the lesion here on the left-hand immediate pre-op, and then you can see it 6 months later here on the right hand. You can see the lesions pretty much healed up. There might be a little remnant, but it looks pretty well healed. I have some more cases here. Here's a retreatment case. On the left, you have a sort of an immediate post-op. I did test number 18. It was vital testing. And then you have a 6-month here post-op on the right-hand side. As you can see, the lesion on this retreatment initially, that's why it's kind of larger on this one. It was an initial retreat, but I'm just showing you the immediate post-op of the retreat on the left-hand side, and then the 6-month follow-up on the right-hand side. As you can see, considerable healing has occurred. Here's another case that was an initial root canal treatment. What you're seeing on the left-hand side is the immediate post-op. And as you can see here, we've sort of have respected the original anatomy of the tooth by not enlarging too large, just kind of sort of letting the original anatomy dictate your treatment is kind of what the focus is now for me, at least, is not over enlarge something, not removing more tooth structure than you need, because you got the tool. You have the powerful laser with the fiber here, the radial emitting light energy that causes the photoacoustic effect. As you saw in those little videos that I showed you, you can imagine taking the tip here at the mid root, and it's causing those little micro or vapor bubbles to just kind of implode and expand and collapse and cause those shear forces. And so here we have a 10-month follow-up that you can see here on the right side with pretty good healing, I would say, in this particular case. And just kind of showing you again more kind of respect of the anatomy, or what have you. Maybe I could have possibly gone a little smaller, maybe at the orifice level, in this case. But again, there's just not much of a need to over enlarge your apices as previous, because you no longer are requiring that syringe to go down to 1 millimeter from the apex, or 5 millimeters from the apex, because you have a very powerful photoacoustic effect that's going to remove that vapor lock and going to remove that dentin debris that's generated from the files. Here's another case here, number 19, just showing you again some of the what you can, the kind of a root canal treatment that you can kind of expect with the laser. Again, sort of keeping it more conservative and allowing you to properly debride and disinfect the system. You can see also the access tends to be a little smaller as well, as you can see. Here's another case. Again, I mean, even with these curvatures, I mean, have to take that to 3006 and try to put an ultrasonic tip down to the apex there. I mean, that would be just very challenging on a case like that, with the abrupt sort of curvature at the end of the root here on that number 31. So again, laser is truly helping us to sort of 3D fill this area, radial endodontics, in these kind of difficult anatomies. So you're having more respect for the original anatomy of the tooth, and you have the correct tool now that allows you to clean and shape the system. Another case here, again, just conservative approach, is a 3-rooted premolar. These are fun, of course. But again, laser helps you. It just helps me to debride the system, disinfect the system. And so we have these, these kinds of results here. Here's an interesting case. It was a bisphosphonate case. What was nice here, again, and I kind of lumped it under conservative approaches, I used my MZ6 tip here to remove some of the gingiva on the distal aspect of this tooth. This tooth was not able to be clamped really, which is another good use of the laser here in this case. And this case had to be treated, and it could not be extracted because the patient on the left side had a recent extraction and had developed a bronch case here, so osteonecrosis. So basically we had to essentially treat this pretty much non-restorable tooth, if you will, to prevent the extraction. And here laser really helped out to be able to disinfect the system properly without without the clamp even, as good as I could isolate it, really, cotton roll. But again, using that laser tip to provide that photoacoustics and disruption of biofilm and whatever limited amounts of hypochlorite I could put in there properly as we kind of cotton roll isolated this tooth. What you see in the middle here is, or sorry, the left-hand side is the immediate post-op. And I did put cavit at the time just because while the laser does a pretty nice job of removing gingival tissue without much bleeding, at the time there was just too much of it, and I was kind of wanting to be conservative about it to not remove more than I needed of the gingival tissue. So I just decided to put cavit in there because I didn't think a composite was going to be a good, was going to adhere properly there. So anyways, I subsequently did kind of laser again more the gingiva, and I applied some resins there, sorry, a glass ionomer there. Here's another case of just respecting the original anatomy. It's kind of small there, nicely done. Here's another case of the crackless axis that I'm talking about in the mandibular. I start my incisors always now with the laser. I may do a laser and some burr and laser again, but I always start with the laser so I don't have that little enamel crack that I see sometimes on these cases. Here's another case of respecting the anatomy again, just you know, just keeping it as true as we can to the original, but also properly disinfecting. Another case here as well. This is my mother-in-law, by the way, and so this is great when you have all the tools in the world to be able to do a great root canal. And I certainly needed them on this one because, as you can see, that pre-op was pretty calcified. But she was happy with the result. Just happened to see her last week. She's doing great. About to get the crown on it soon. Another case here, just to show you again what you can do. Number 30. I'm trying to move a little quicker here because I know we're sort of coming toward the end, and I want to answer any questions. And we only have just a few more to go anyways. But another case here. Respecting the anatomy again, just trying to, you know, getting those fills, radial endodontics. Here's another case, number 14. I think that's it, yeah. So that allows me, you know, a good 10 minutes here of questions. Hopefully there's quite a few, or if anybody
well,
to talk about
not so far, Dr. Meza, but sometimes they pop in as you finish there. So number one, thank you for a really engaging presentation. I appreciate that. Particularly, I'm impressed with your videos. Such a great way to visualize some of the action that you're talking about. Thank you. Yes. So while we wait to see if any questions pop up, I'll just remind everyone that you can either, preferentially type them into the Q&A button there, or certainly just into chat if you're in chat and you have a quick one. If not, we will go forward, but I'll just wait a minute for those. Dr. Meza, maybe you can speak a little bit to the implementation of technology into your practice. I know you haven't always used a laser as you've shown here. You know, what do you think some of the benefits to you as a practitioner have been by implementing the technology? Well, one of the main things is that we were, if you're a 2-visit office, all these cases have been done in 1 visit, and so that's a very important distinction. And right away there, you can increase your you know, your productivity, and also patient are happier not to have to come back. And so I'm seeing that very predictable healing, and also very predictable decrease in post-op you know, sensitivities. You know, even in doing them in one visit like this. And so we were always kind of 1 visit anyways, but I've seen even less post-op sensitivity or cases that kind of come back, you know, to you. So that's been one really good thing about that. Yeah. Great. Maybe one other question. We do see a couple populating right now, so we'll have a few to ask you from the audience. You had mentioned some of the time of this procedure, other procedures. Would you say that you were spending more time per procedure, less? Is there something you can quantify there? Yeah, what's nice about the laser is that it really kind of just flows through your
your existing technique. You almost think of it as like grabbing the apex locator at this point, or grabbing your ultrasonic unit at this point. It's like you're just grabbing the laser tip at this point, and just going right through the motions of your root canal treatment. I tend to use it throughout the treatment. Some people will use it exclusively all the way through it. You can use it when you start your access. You can use it when you're in your pulp chamber to debride the pulp chamber. You can use it obviously as you're instrumenting down the canal. And some colleagues will use it towards the end only, basically, just to, and they haven't really changed their technique, but they're applying the laser tip all the way close to the apex or mid-root to the apex, and they're really getting that great photoacoustics, disinfection, and dentin debris removal that we're talking about. But so those are some of the nice things that it, why for me it hasn't really increased the time. The other nice thing is that all cases pretty much are used, are acceptable for laser use. I can't think of any case really where I just don't use the laser. So there's no decision-making process beforehand. It's like, oh, is this a case I can use the laser or not? Pretty much every case is usable with laser.
Great. Thank you for that. We've got 3 or 4 questions here, so I'll get to those. This appears to be from Dr. Moreland. Can you tell us about the speed of cutting enamel with the laser? How about bone? Right.
So actually an anterior tooth it's all going to be slower than a burr, no question. And so I actually kind of use the technique where I start my access with a mandibular incisor, particularly, or an anterior incisor with the laser first to not have that crack induced. And then I may open that up, a bit, and then maybe go into a burr for a little bit and go back and forth. So clearly, if you're used to, going through lots of root canals a day, you like your speed, trying to access particularly a molar with the laser is going to take some time. Can it be done? Yes, it can be done. I would focus on trying anterior teeth first, because that kind of gets you going, and it doesn't take as long to access those with the laser. It's hard to put an exact time on it, but I'm not sure if I could really say if it's twice as long as a burr or not. But clearly, a molar will take you a significant amount of time to access through. And it's challenging to do that. Yeah.
Thank you. This is from Dr. First. What is minimal instrumentation, tip, and taper?
Okay, so for my cases here that I've done is I'm doing about a 2004 or sometimes a 2504. On the larger cases, I'm just kind of respecting the original anatomy of the walls. And I'm kind of just using headstrom files like in palatal canals or distal canals that are just kind of barely touching essentially the wall, and not really relying too much on dentin removal with a file, because I know my laser is going to go and it's going to penetrate through dentin to a certain degree, and it's also going to, the photoacoustics plus the either the distilled water that goes through it, as well as the sodium hypochlorite, will disinfect the system. So minimal could be, thought of, I guess, for many people, different things. I've seen some practitioners or colleagues of mine finish at maybe a 1506 perhaps, or or even potentially something smaller. So again, it's the power of the photoacoustics that allows you to do that kind of thing and get away with it. Yeah.
Thank you. This is from an anonymous attendee, and I'm usually careful with those, but seems pretty straightforward question. To use the PIPS effect with the YSGG laser, do I have to place the fiber into the canal, or is it sufficient to hold it in the pulp chamber?
Correct. So the PIPS technique was with erbium YAG laser, and both the YSGG and the erbium YAG have most of their absorption in water. That's why they're similar. They're the same family, and they got similar wavelengths. Erbium YAG is at 2940, and the YSGG is at 2780, and so they're going to be similar. So if you want to use, if you want to place it in the pulp chamber, You can go different ways. You could use the RFT2 tip in the pulp chamber. You can use an MZ59, which I like to use in the chamber. You can also use an RFT3 to get a little bit more energy through it, just because it has a higher coefficient factor. You can also kind of apply that sort of pips or that kind of sort of, again, photoacoustics, I'm going to call it, in the mid-root or in the orifice. You know, as going back to my videos, the reason I show those videos is you can see that the effect is at a distance. And I think that's the main thing you want to kind of understand about it, is you can have an effect at a distance. And if you want to go closer to the apex, you're going to have an even more powerful effect there, of course.
Excellent. Thank you, Doctor. Let's see. Sorry, I misplaced my questions. This is from Dr. June out in South Carolina. Hello, Dr. June. She has two questions. I'll ask them both. They're quite short. It should be easy to kind of keep them apart there. How do you use the Waterlase for a pulpotomy? Same as a pulpectomy? Question mark. And then the follow-up question is, what is your favorite tip for cutting into enamel?
Okay, so I'll take the second one first. Favorite tip to cutting into enamel would be either the MZ59 tip or the MZ6 tip is what I would say to cut into enamel for me. And then I think you said for, pulpectomy or pulp chamber. So there's two effects here that you're kind of going for. One is a direct ablative effect similar to soft tissue that you're going to have with an MZ6 tip, for example, on gingiva. You can have an ablative effect on pulp tissue itself in the chamber with that as well. But what we're working with here as well is a photoacoustic effect that in some cases may not be powerful enough unless left for a long enough time. And again, I sort of try to figure out the efficiencies of root canal treatment here, but in some cases, it will dissolve the tissue along with hypochlorite. But you got to keep using hypochlorite, and you got to keep you got to keep the fiber in the pulp chamber for significant amounts of times for all that tissue to be completely dissolved. Can it be dissolved? Yes, it can, but I think a faster way to do this is we're still using files to remove the bulk of the tissue is what I like to do. And then what I often see after I've removed the bulk of the tissue, whether it's with a burr in the chamber or an orifice opener, and I've gotten rid of the tissue in the orifices, as I don't see any more tissue in the canals and I'm using hypochlorite, I'll activate the laser tip mid-root, and all of a sudden, as I withdraw, several times, I'll start to see a little bit of bleeding that comes through. And that's just telling me that I'm starting to get some of that small tissue at the apical ends of this. I'm affecting some of that. And so that's where I think the power of the laser is, the photoacoustics of removing remnants of little tissue fibers, or perhaps maybe, that reside possibly in the apical end, where you're seeing just a little bit of that stimulation come through. And when I say bleeding, I don't see bleeding, profuse bleeding. I see cleansing, I see a little bit of bleeding, but that stops, and so to me, I'm getting some of that little bit of tissue that perhaps before the file wasn't going to grab onto that area. Going back to the Peter study, just not touching all the walls. So you might have a little piece there at the apex that you're not aware of, because tactily we can't feel it unless you enlarge it really, really large. Perhaps maybe there it just goes away anyways. But with the photoacoustic effect, you can start to see some of those little bits come out, and some of that stuff that you thought you got out, beforehand. Yeah.
Sure. A little bit more about that. You had mentioned apico and bone. How do you use it during, you personally, doctor, how do you use it during an apical surgery, and, bone removal during an apicoectomy, and visibility? What have you found?
Yeah, so visibility is great because you have, there's two main types of tips that I like to use. One's an MC, as in Charlie, 3.9, and that's a 9mm. So that gives you pretty nice accessibility through a microscope. The other one is a side firing tip, 8, which is I believe is an 18mm tip. So that gives you a pretty nice also view. So I like to use both of those, as well as the MZ6, of course. So the MC39 is used for my incisions, and I can do a sulcular incision with that, or I could do a submarginal incision with that, and of course my release incisions. And what I found is I see less bleeding on my incisions for sure. Then, as I've reflected the flap, I could use an MZ6 tip to apply it to bone removal, which is very possible, but that's going to be something where I would say you start to tackle a little bit later on in your apicos if you choose to, because it can take a little bit longer than a burr. And so for my taste, I tend to switch to a burr at that point to resect the root, although you can absolutely, because it's an all tissue laser, use the MZ6 tip to resect the bone and to remove the bone and also resect the root. I tend to do those more with a burr. I may refine the prep with an MZ6 if I so choose. But what I want to get to is the side firing tip. This is a must. The side firing tip allows you to disinfect the root end preparation in a way that we've never been able to do so before. What I mean by that is that we used to just use the ultrasonic tip to remove the gutta-percha, and then your syringe irrigating with like a saline solution. That may be some level of disinfection, but it's not quite the laser level of disinfection that you can achieve. And remember that the laser energy does penetrate through the dentin. So imagine resecting the end of the root and applying a side firing tip that's 90 degrees. It's aimed 90 degrees with 18 millimeters of visibility. It's a very nice tip. You can basically etch the entire root end prep as well as the root end resection portion, and have photoacoustics and disinfection occur inside the root end prep in a fashion that we've never seen before. And so I think we're disinfecting the root end preparation to much higher degrees than ever before with this. So I would focus more on, especially when you get started with apicos, is the MC39 I like, and then the side firing tip 8 for disinfection at the end. Those are my two favorites. Of course, you can use the MZ6 if you like to remove bone and resect the root. You can. Absolutely, you can.
Perfect. I think that's all we have time.